Good afternoon. I'm Monica Hendrickson, the Public Health Administrator for the Peoria City County Health Department, and welcome to our weekly Tri-County update regarding COVID-19. For the counties of Peoria, Tazewell, and Woodford, we currently sit at 19,075 cases to date. That is an increase of 2,294 cases from last week. That brings the to-date total for Peoria to 9,751, Tazewell County at 7,391, and Woodford County at 1,933. Our to-date count in terms of deaths now is at 269, which is an increase of 25 from last week. We are sad to report today 3 additional deaths amongst Peoria County residents: a male in their 50s, a resident of Sharon Elms, a female in her hundreds, a resident of Lutheran Hillside, and another female in her 70s not associated with a long-term care facility. In addition, Woodford County is reporting 2 additional deaths, a female in her hundreds and a male in his 70s, both associated with AC Eureka. And that brings the to-date count for Peoria at 137, Tazewell at 102, and Woodford at 30. To give perspective in terms of our numbers, in November alone, the Tri-County saw an increase of 9,214 cases. That is 3 times what we saw in October, which was 2,936. As well as in September when we were just slightly at over 2,000 at 2,036. While our 7-day and 14-day daily averages have gone down slightly to 328 and 335 positive cases daily respectively, we understand that this is still a little bit low than we expect at this time, partly because of the holiday testing sites that were closed on Thanksgiving, as well as recognizing that individuals that traveled or maybe not adhered to some of the guidances that were requested during the Thanksgiving holiday, we expect those numbers to start showing up later next week and the week after. Overall, close to 66% of our cases in the Tri-County are considered recovered, 32% are at home isolating, and 0.4% are hospitalized. In regards to our hospitalizations, overall for OSF St. Francis Medical Center, Unity Point Health, Proctor, Pekin, and Methodist, there are currently 49 ICU beds in use, 4 for persons under investigation and 45 for those confirmed, and there is currently 119 non-ICU beds in use. The hospital systems are saddened to report 5 deaths in the past 24 hours related to COVID-19. What we have seen in the hospitals is continued ICU usage increases. From last week, we are now at 54, while previously we were at 44, while our med-surg is slightly declined to 122 beds in use. To speak more about the hospital systems and their capacity, we do have a speaker today, Dr. Sater from Unity Point Health.
Good afternoon, everybody. Thanks for having me, Monica. In the hospitals, especially at Unity Point, we have had a significant increase in the number of patients that are requiring hospitalization. This has been going on for the last few weeks. Every few days, we seem to get a little bit better, and then we immediately have a little bit of a spike again. We have not had any significant shortages regarding ventilators or the physical number of beds yet, but that has required management by our nursing staff and by our medical staff. By that I mean that we're looking at every day at how many beds we have available, how many nurses we have available, what type of surgeries are coming up, and we're trying to take into account the total health of our community. meaning that if somebody requires a surgery that is semi-urgent or would affect their outcome down the road, for example, you have a cancer, and if we do the surgery soon, we increase the likelihood of that cancer being cured, we're not delaying those type of surgeries. But it is requiring that we look at our resources every day and make decisions about what we can and cannot do the following day. We appreciate the community's help. People have been working under what I would call duress for the last few months. Our nursing staff, nurses, aides, respiratory techs are really putting in extra shifts. Our medical staff and our nursing staff and other auxiliary type of people who help care for patients, that includes EVS, dietary, we all live in the same community. So when the numbers are going up, that is affecting our capacity to have all the staff that we want to have in the hospital to care for all the patients, meaning that our staff is also having infections, and we have to quarantine and isolate quite a few of our nursing staff and adjunct team members. With that said, we appreciate any help from the community in the sense that if our numbers go down, we hope that the number of people requiring hospitalizations go down. I ask people not to only think about your exposure level, but if you're young and healthy and you're taking some risks, consider who you live with, consider who you work with, consider the place that you work at. So that if you're young and healthy, but you go work in a nursing home or in a communal type setting, that you may be the source of infection for a person that ends up more likely to be in the hospital. So when I'm asking people to be careful if you're vulnerable, also be careful if you care or live with a vulnerable patient, because those are the type of persons that are ending up in our hospitals, staying in the ICUs for a long period of time. As Monica just said, you could tell from the ages that these are not young people, but when they end up in the hospital, it affects our resources the same. Thank you, and I'm happy to take any questions, Monica.
Are staff being told not to do things, high-risk things like travel, or, are the nurses being told that?
We are encouraging, and what I would tell you is that the nurses and medical staff, we're no different than the rest of the people. There is some degree of fatigue. We are used to working in the healthcare environment next to each other. Part of that camaraderie that we enjoy is part of our normal life. But we do advise people to be cautious. We go around and do infection control rounds to make sure that people are wearing their mask. We're making, at least at Unity Point Health, we have special sensors on our badges to tell us how good we're doing with hand hygiene. And we do ask people to spread out as much as possible. There is nothing better than distance between people to avoid infection. So physical distance is critical. And we do ask people to think about what their plans are. We are not asking people we're not forcing people to stay at home, and we can't. And it's not our job to really enforce that. We just ask them to make as good a choices as possible.
Doctor, there are some hospitals that have kind of waxened or loosened their quarantine protocols to address those staffing shortages. So maybe previously I would have quarantined if I had X amount of exposure, but now I'm not. Could you kind of explain what Unity Point's policy is on that?
Correct. So if what we go by is by symptoms. So we're all masked and we all try to follow hand hygiene. So if you get exposed in the hospital, you would have to be exposed with eye protection, mask, and hand hygiene. So we're not quarantining people just because they cared for somebody with COVID. Now, if you had a close encounter at home where you were not following those precautions because it was your spouse, then yes, we are asking you to stay there for at least 10 days. We know that most people who develop symptoms will do so by day 10. So we're following that. The CDC may be coming out with new guidelines for testing to bring people back to work. We're looking at those. We did that a lot at the beginning. And when we didn't have shortages of staff, we were able to say, okay, just take the full 10 days, assuming that you are a normal, healthy person. Remember that the 10-day recovery is if you are healthy. So if you're a transplant patient, if you're a cancer patient, if you're receiving immune therapy for autoimmune disorders or otherwise, that actually takes 20 days. And we're pretty strict on that for patients and for staff.
Do you have a number on how much of your staff, is out at any period of time with this quarantining, with infections?
Yes, we try to keep track of that, and we keep track of how many are related to work exposures, how many are related to what we think is outside of work exposures. We're very liberal with the definition of work exposure to give, since we are taking care of people with COVID-19. So we keep close tabs of that. We may have, recently we've had anywhere from over 110 to 120 people out with COVID-19. Probably about a third to half of those sometimes are related to people who take care of patients directly. And those are the ones that are most critical for us making decisions. So we do keep track of it, and most of the people getting infected until recently has been by far community exposure. A lot of it is coworker exposure, and then there is some patient exposure. But if I had to rank our total numbers, it is community, coworkers, followed by patients.
So you said you have a kind of a literal definition or a very strict definition of what a workplace exposure is, whether that be a patient or a coworker. How do you define that?
So if we cannot find out a good explanation, we always say it was something in our facility. But if you tell me, yes, 3 of my friends tested positive, we were out past weekend, then that's a pretty clear exposure. My spouse, my kids. So we do a little bit of what we do call the contact tracing that we talk about. So our employee health does that. And we try to look at it as reasonable as possible for 2 reasons. We're looking to define if we have an outbreak in our facilities and if our practices of PPE and hand hygiene, if we're up to the standard that we need to be.
When you say you've had as many as 110, 120 people out.
Or more. Yeah.
Is that kind of a number that's gone on for weeks?
Over the recent weeks, yes.
In recent weeks. And
Yeah.
what percentage of that is of hospital staff? 110 people, that's a big facility. That could not be a high percentage.
Correct. Like I said, about half of that is related to people who take care of patients at the bedside. We do employ over, I want to say it's over 4,000 to 5,000 people, some between that number. So it's not a huge percentage, but we do know that the positive rate of when we test employees or anybody in our labs, we keep track of the positivity rate of anybody that comes through our facilities who gets tested, and that includes our employees. And it's been going up, and it's in the upper 20% now. The last number I saw was in the 20% plus range. So it is significantly higher than it had been in the past when we were single digits a few months ago. The last couple of months, it's been steadily moving up, and I think our record is somewhere in the upper 20s.
So the positivity rate, how frequently are you guys tested? Do you test the doctors and the nurses and everybody, or you only test when they get symptoms?
We test when they get symptoms, or if there is a specific outbreak and we're doing an investigation, we may test more frequently. We also have a nursing home at Proctor that's requires to get testing at a certain frequency depending on how many positive tests there have been there. Recently, we are at the lowest level of testing at the nursing home.
You said there's no shortage of ventilators or physical beds, but do you see that becoming an issue in the coming weeks as we see the fallout from holiday travel and get-togethers?
It is possible. That's why I'm here today, really to give you some idea of what's happening in the hospitals and asking the community to help us lower that positivity rate so we don't have to think about that. And when we talk about resources, we want to take care of the entire health of the community. So we're not just talking about COVID patients. We're talking about car accidents, strokes, surgeries that may require those resources. We want to make sure that people are not going without health care that they need for any significant amount of time. So it's not just related to COVID. We want to make sure we have resources to care for everybody. Do I envision a shortage in ventilators? At this point, it does not look like we will reach that point. Between the hospitals in the community, the state resources, the federal resources, and I'm not even counting our own healthcare system resources from Iowa, I think that it looks like we have enough, but you never know. We prepare for those eventualities.
Thank you, Dr.
Thank you.
And I did want to make one clarification that when Dr. Sater, as well as our healthcare communities, because of the nature of the work they do, there are different quarantine practices that go towards our healthcare workers, and those guidances can be found on the CDC website as well as the Illinois Department of Public Health website. But the key thing to understand is that when we do have staff in the hospital systems or any of our critical infrastructure, there are ways for them to be released from quarantine, but that's only for going to work. They're still under quarantine for other things, such as going grocery shopping, participating in other activities. It's just for work-related, they do get a release for quarantine reasons. And kind of speaking of quarantine, because I know the news has been out there, the Centers for Disease Control and Prevention, or the CDC, has issued new recommendations around quarantine. Now, best practice still continues to be 14 days. The science and the data shows that's really the effective time period overall. However, based on local circumstances, as well as needs within the community, there are ways that quarantine can be shortened. The first is that it can end after day 10 without testing and with no symptoms. However, those individuals have to continue to do daily monitoring. So if an individual is not doing daily monitoring, we can't assess whether or not they are without symptoms at day 10, and so they would not necessarily be able to be released at day 10. Likewise, individuals can, if your community has enough testing, get a negative test result and end after day 7. However, this test has to be collected 48 hours or 2 days before the end of their quarantine period. So again, the testing-based one also is dependent on the availability of testing resources. Now, right now in our community, we do have a lot of great testing opportunities, but the priority for testing is always going to be individuals that are symptomatic. So the priority is always about infection control and not necessarily to shorten quarantine periods. Now, this guidance is relatively new. It has been teased for a while now, but it did finally get released. We at the local health department are now waiting for final guidance from the state because there are processes and procedures that will have to be updated, including even return to school guidance. This has not been finalized. So until that has been finalized, we're going to be operating still on the 14-day quarantine period. Once those changes are made, though, we will be updating moving forward. We'll be going and trying to collect some of our cases that would be impacted, changing their times, and then, of course, working with our school districts. The key to also remember when we talk about quarantine, and Dr. Sater really mentioned it as well, is that depending on when your exposure happened or the type of exposure really impacts your risk of developing the virus. And we find that households are ones where the virus spreads really quickly. And so with that, even when you are in a household with someone that is being quarantined, they need to be separated away as much as possible. So while this new guidance, changing it to day 7 or day 10, is, I think, exciting news because there's a lot of people that 14 days can seem like a huge burden on them. When we talk about household implications, it might not be a drastic change that people are expecting. So again, this will be as a case-by-case basis through investigations with our contact tracers to determine what type and how long your quarantine will be for. The other thing I wanted to bring up, I know we've gotten a couple of questions about, is in regarding the enforcement. I know there are questions regarding the enforcement of the executive orders in Peoria County. Just to, again, provide a review of how the process works in our county. Our process is complaint-driven. In the beginning, someone or an entity provides a complaint or an issue or concern, and they register it on our Restore HOI website. Now, we do have direct complaints that come to us from other entities, such as law enforcement or code enforcement. But for general public, we request all of the complaints to be going through Restore HOI. From there, all Peoria County complaints are referred first to the proper agency. So depending on the oversight or the licensing of that facility, it might be the local health department, it might be your city of Peoria, code enforcement, it might go directly to the DCEO. Based on that, I can speak that the first thing that happens is that there is a follow-up notice or first notice that includes a call and education around the executive order, as well as any material that that agency might need. It might be that they need signage, they need it in different languages, helping them explain to them the importance of why these executive orders are there. If additional complaints come in, a site visit is done and a second notice is issued, as well as directions on how to do corrective measures. If this continues to be an issue and there's a disregard of the executive order, then a third and final notice is provided to the state's attorney's office. Now, after discussion with our state's attorney, we consider these ongoing investigations because of the nature and the implications they have. So we will not be sharing any specific names or the specific reasons of those complaints at this time. Again, just wanted to give an overview, and we are always accepting those complaints through the Restore HOI website. And we do know that we are getting complaints from different counties. Those are forwarded then to those counties themselves.
Can you say how many complaints you've gotten?
I can say that it's been roughly 100, but that's been registered on the site. I can't tell you, though, how many are our county or other counties. But we know it's being utilized, and we actually do appreciate that people are using that because that is a great centralized point for not only us, but those other entities to receive that information.
Can you say what the most common complaint is? Is it like indoor dining or not wearing masks or?
I believe all the complaints are regarded to all of the above. I think there's lots of issues regarding just capacity, masking. It covers the gamut, and which is expected when we have those type of executive orders. And there are a lot of questions that people have. So again, directing them to the Restore HOI website would be where I would highly recommend everyone utilize. And also the mitigation is updated there as well. So when there's any changes to the state, it's also posted there so people can know what the current guidance is.
And when people receive citations, when these businesses receive citations, do they come from the health department or do they come from the police department?
So the question is about the notices. It really depends on, again, what the entity is that is the most related to that business or that type of activity, whether it's a food establishment, it might be the health department, it might be a gym, so it might be DCEO. So it depends on really the entity that is most attached to any of the regulations of that establishment. And again, the thing to note is that these are related to entities, not individuals. And so really that's one thing that we want to focus on when we talk to people about that. It's really the entity and their adherence to it, not an individual that you might see in the middle of a store or something. Yeah. And the last thing I do want to discuss, because if you're not aware, I think today hits our 9-month mark that we've been doing our Emergency Operations Center in some form or capacity. And there is that horizon out there, which is our vaccines. We are very excited that we hope by the end of this week that the FDA will have given the emergency authorization for 2 vaccines, and then from mid-December to the end of December that we will start seeing the first shipments arrive here locally. It is the best way. It is going to be a process. There's lots of multiple steps to it, and as you are all well aware, there are logistical needs that have to be addressed. The first vaccine we expect to come out is the Pfizer vaccine, which does need to be stored at negative 80 degrees Celsius. And then followed by Moderna, which will be stored at negative 20 degrees Celsius, which is common to some other vaccines that we are used to having. Now, overall, the vaccine process, I know there's lots of questions that have come out. ACIP has already given out their recommendations on the steps and how they want the vaccines to be distributed. We know that the state will be issuing their plan, hopefully sometime over this next few days. And then from there, we will start really looking towards the planning and processes and really, like I said, taking and putting those details into our structure about how it's going to be distributed. Again, we know there's going to be limited amounts, so it's going to be a phased or tiered approach. But the key thing to recognize with vaccines, and we'll actually, I think, have a speaker next week to talk more about how vaccines work, is that we really are looking to get 80% of the population vaccinated. That's where we'll be at a level of immunity or herd immunity that we can start looking about coming back out of these different type of mitigation levels. So again, very excited. There is a horizon. Now, the way vaccines work in general is that once you get vaccinated, it does take time for your body to create those memory cells on how to fight the virus. And in the case of COVID, there are 2 doses, 28 days apart. With that being said, it doesn't mean that once you get vaccinated or even the thought of the vaccine coming is a way for us to lax any of our mitigations. In fact, it's even more important because as we wait for enough of the vaccine to come into play and be distributed, we want to make sure that we give all of our community a fighting chance. And so again, continue watching your distance, wearing your mask, and washing your hands. With that, I'll open up to questions.
In terms of the vaccine distribution, do you see the vaccine becoming like a requirement for children entering kindergarten like other vaccines are?
So the question is about requirements of the vaccine specifically for children. Right now, I believe the vaccine has only been tested for individuals 18 and older. And so I think that the guidance currently is for adults. Doesn't mean that they're not already looking at dosage changes for children. In terms of requirement, right now there is no mandates for getting vaccinated. However, we do have certain guidance and principles in place, for example, for influenza vaccine. So we have different employers that might ask you that if during flu season you choose you choose not to, not because of medical reasons, but you choose not to get your influenza or your flu vaccine, that during an outbreak situation, that you might be asked to stay home and use your own benefit time. And so again, there are different parameters, but right now there's no mandates. And again, that's because we have a limited amount of vaccines. So as soon as we get it, if someone says no, that's okay. There's going to be another person that needs to get it right away.
Do you have a sense, I know you said that the state was working on the plan, the distribution plan, but the CDC has already made their recommendations on who should get it first, which I think was like nursing homes and
Healthcare workers, yep.
yeah, medical people. So do you have a sense of how that's going to happen here?
So we're going to follow the ACIP guidelines in terms of how we prioritize vaccine. I think the key is that we're not going to get enough to cover that entire population right off the gate. And so with that, it's even prioritizing within each groups. So for example, again, as an example, you might have a nursing home that has 100 residents, of which maybe 20 are considered really high risk based on a lot of the comorbidities that Dr. Sater and other physicians have shared with us. If you get a vaccine allocation of just maybe 20, your first tier might be those high-risk residents, and then you would move down. And so that's why part of the planning process, and this has been pushed out to long-term care facilities and a lot of our community partners, is start looking at how you would prioritize based on skill sets, vulnerability, et cetera, in your groups that you work with.
Yes, one question I have is there's been some polling on this, and it shows there's some significant skepticism among parts of the population about getting COVID vaccine. So we're talking about 8% needing it to build that herd immunity. It means, you as a public health department are going to have some convincing or persuading to do. So, how are you strategizing to convince people, A, this is safe, and B, here's why you need to get it?
So the question is, with a lot of maybe distrust around vaccinations and the history of medical interventions in general, how does a health department really approach that? And we've had to fight that fight for a while, actually. Not just with COVID, we fight it every year with influenza, along with any of our vaccines out there. because of some misinformation that can be out there. I think part of it is education. The other part that we're doing here locally is we actually have community outreach workers that are creating champions to educate them on what a vaccine is and how it works so that they can communicate to their peer network as well, because oftentimes people don't necessarily trust the public health administrator or their physician, but they will trust their friend or their aunt about what that means. I think part of it is starting with misinformation. So I often hear that people don't want to get vaccinated because they think they get, for example, the flu. And in fact, when you get a vaccine, you should expect a reaction. That's the normal process of getting vaccinated. Think about it. You're putting something in your body. Even the food you eat impacts you. So there's always a reaction. So oftentimes, when you get a vaccine, you're going to have some soreness. You're going to maybe develop a slight fever, some chills, muscle aches. But that's your body naturally responding to the fact that you just put something into your body. So that's something that we expect, is that those are normal symptoms that you have for any vaccination program. I think the other concern is the timeliness. People are concerned about the fact that it has gone too quickly, maybe. And the speed is not what concerns public health professionals at all. Because think about this, never in our history have we seen the entire scientific community decide to focus on one problem, and that's building a vaccine. So the speed doesn't necessarily as an issue when you realize that that collaborative or that crowdsourced approach to kind of finding a solution is going to make things speed up. What's important is looking at the data, and that's what the FDA is doing right now, is reviewing the data, looking over the studies to see that safety, the effectiveness, and making sure that there is, going to be a process that makes it equitably distributed. And so, I'm not going to be tier 1. I'm not a healthcare provider, and I don't live in a long-term care facility, but I can say when it's my turn, I'll roll up my sleeves. Excuse me.
Where will the vaccines be stored?
Where the vaccines will be stored. So it's going to be really dependent, because that type of vaccine, the Pfizer vaccine, is very specialized. The containers that they come in are able to be recharged using dry ice. But again, it's going to be a massive, this first push is going to be a massive logistics approach that the state coordinates.
And that's the negative 80-degree one.
Yes, the Pfizer one currently is stored at negative 80 degrees Celsius.
And how big a deal is that? Negative 80 degrees Celsius? That's not a normal refrigerator. I mean, do you have to get special refrigerators to do that?
Yes, there is going to be a lot of specialized equipment to store that material. But already Pfizer is looking to, at the next variation of this vaccine, as they keep, looking at improving it, to get it down to a point where hopefully maybe it can be even at room temperature. But right now, it is going to be at negative 80 degrees. And that's why the Moderna, which is the next vaccine that's coming out, is also really looking at how do you share that one, because that's stored in a way that we're used to in public health and in healthcare at negative 20. So that's something that we can manage at a local level. But it's going to be very much a logistics, also because of just the size and volume that's going to be shipped out. And so for the next few weeks, there's, again, another planning, and public health is going to pivot, and so is healthcare, to address another part of this pandemic. Well, thank you all, and you guys have a great day.